Hi everyone, I'm Dr. Swaratika. I'm a consultant and an assistant professor in Bangalore. I was hoping to give this talk in person, and that's why it's a very short and a sweet presentation, because I was hoping for it to be a more interactive session. However, that wasn't possible because of some issues, but so I'll just start the talk now. I would like to start by thanking Dr. Vanita and Dr. Anand and the entire Geriatric Oncology of India group, because it's a shared passion that has led to this workshop as well as any future collaborations. So my topic is designing trials in older individuals and a way forward of future perspectives. So we would start by what are the types of trials that we know we have. I'll talk about clinical trial methodology, the observational studies that we can plan, as well as collaborative consortiums that we may form and that are already in existence. Once the patient comes into our clinic, there is multiple time points at which a same patient can be recruited for studies, right? So when an elder patient comes, that is not surprising either, but you can start recruiting them for either a cohort or an observational, or even their medical records then becomes a source to plan studies. This can be at the time of diagnosis, where we talk about whether or not they're even willing to undergo a cancer-specific diagnosis. It could be related to therapy and the toxicity, and therefore on what the kind of therapy modifications that we can plan, or the kind of toxicity assessments or geriatric assessments that we can do. It could deal with survivorship issues, that is after completion of therapies, of their allotted therapy. Survivorship issues are obviously not given enough or due importance in the geriatric population as they are in a young adult population. And I think it's about to change, because the definition of the elderly is decreasing as well. Before, when it was considered above 75 versus above 60 now. And with our current life expectancy of 85, we have a huge cohort of patients who are above 60, being diagnosed with cancers like lymphoma or breast cancers, or germ cell tumors even, who can contribute, who will form a big cohort, who will have survivorship issues. And we can also conduct studies which regard to the attitude or knowledge, attitude and practice studies when they come to our OPDs, even for a routine follow-up, or at the time of screening, or at the time of any time that they come in. We can consider them to be enrolled into some study that we have planned. So we'll talk about how all these studies in my future slides. At the onset, I'd like to say, I'd also like to remind that although geriatric population is not included, or it's not the forefront of most clinical trials, the fact that these following trials were conducted in the geriatric population has been a game changer in malignancy management. And that is why we must never ignore disease biology in the elderly. So remember now that azacitidine and venetoclax was actually first studied in elderly AMLs who are above 75 and considered unfit for that current standard of care, which was high-dose chemotherapy. But somebody thought that this population, maybe they're not fit for the correct standard. However, their outcomes are actually much better, and azacitidine and venetoclax is now being used in much younger population also, just because it spares them of the toxicity and has gone into remission. The other game-changing trial that was first evaluated and gave the world rituximab was actually the GILA trial, which looked at rituximab alone, because the elder population, that is the above 65 years category of patients at the time, were not considered fit for dose intensification, and that's why they first studied rituximab in this population, and then they realized that okay, they were doing so much better, and therefore rituximab has gone all the way from geriatric to adult to young adult, and now even pediatrics uses rituximab. The other most common misconception is that maybe perhaps elderly patients are not fit for very dose intensive therapy, but again, cross-sectional or even retrospective chart audits have given us adequate answers to say that perhaps prior to dose escalation, we must study this population in greater detail to say whether one entire cohort is fit or not. And they have found FOLFIRINOX is tolerable in many patients with pancreatic or colorectal cancers. So now coming to the need of the study, right? So we'll be so one is that when we're designing or talking about clinical trials is to define the patient inclusion criteria. So now what is old? It's a rather arbitrary definition. Some people have taken 75. Now people are taking 65. The trials which have taken 60, and we have a trial in AML running, which they've defined elderly population as 55. And I think we're just going to hop from a young adult population from 39 years of age to right to the geriatric population or elderly population in no time. But this is because you want to include as many patients in your trial, and maybe we should reduce the age of elderly, and therefore we have to redefine that state as we spoke about functional age. The other thing that we define when you define a patient is to not only ask about the functional versus the chronological age, but also assess when you're seeing in your patient inclusion criteria is for frailty. We've spoken about how to assess, although obviously there's no strict definition and people have various definitions of frailty, but it's only suggested because when we take into account of a frail individual, we want to know whether they'll be at a higher risk of cancer-directed toxicity, because or they might even have therapy-related outcomes which I have not taken into account when you're designing a trial, which is not for the elderly population, such as functional loss or further cognitive impairment, etc. Then we come to selection of patients. Now, why is it so difficult to conduct a trial in elderly population? Is because all elderly people are not the same. Whether they have having one comorbidity, one patient at the same age, having the same comorbidity, have various levels of severity of that same comorbidity. So this makes treating that individual difficult, because although we know that the outcomes will be poorer in those with uncontrolled diabetes versus controlled, the people on paper, they both tick the same boxes for inclusion. So when we are thinking about designing a trial for the elderly, we should be as broad as possible, but given that there is a lot of heterogeneity amongst the older individuals, and they're obviously unlikely to tolerate or benefit from standard therapy. Now, it is because of this ambiguity of selection of patients, which has led trialists or those with which has led people to not include elderly population in the in interventional trials. However, as geriatric tools or comprehensive geriatric assessments become more validated, more fine, and more sharp in order to select in whom an actual therapy benefit will be there, this problem will also slowly go away. Next, we come to comprehensive geriatric assessments, where we group the patients into fit, older, frail, unfit, or unfit and unfit but non-frail. And when we design a trial in our setting, we can also consider including patients or subdividing patients or substratifying stratifying the patients as per a comprehensive geriatric assessments, rather than just putting it into age brackets, that is 50 to 60 or 60 to 70 or greater than 70. So when we include these parameters, it definitely makes it a more applicable study. Next is the question of underrepresentation. Now we know that the geriatric population is really underrepresented in clinical trials. 35% of our patients actually belong to the age group of 70 and above. However, they comprise of only 9% of patients who are included in the trial. Now, underrepresentation might be physician-related, that is the trial, physician-related, trial design-related, or even patient-related. What we can do while designing trials or while planning studies in geriatric population is, one is to enhance their involvement in trials. Now, whether we do an age-specific trial or age-unspecific trial, we need to understand that we need to restructure geriatric assessments before blindly considering them unfit for chemotherapy or for any planned therapy, given due to their age alone. Now once we have decided that we're going to do an intervention trial in the geriatric population, and we have tried to make a selection criteria which is clinically applicable to our patient setting, or stratifying them appropriately, we can decide whether we want to do an age-specific trial versus age-unspecific trial. So the advantage of age-specific trials are obviously that you're going to improve the accrual, right? So if you have a patient looking at outcomes in just 60 years and above, and you're looking at, for example, a cancer like pancreatic cancer, which is seen in those in the 5th or 6th decade, it improves accrual, it improves applicability of the results. And when you include an age-specific trial, you know that you can focus on toxicity and function as well, and you're not looking at efficacy alone. You can integrate, while planning the trial itself, we can integrate geriatric assessments, and we can even stratify patients based on geriatric assessments rather than the chronological age. And therefore, when the results come out, they become more generalizable to the person in a real world scenario. And when you know that this is a trial which is designed for an older individual, and you're telling the patient that, okay, this is a trial which is looking at this disease in your age group, they're more keener, they're more likely to participate, they're more likely to stay on the therapy that they have been allotted to. And it may be safer because you're designing this trial keeping their physiology in mind. So based on that, we can either have safety, efficacy based trials, and like I said, we can stratify them, and therefore under each geriatric assessment they can be stratified. So therefore, you can have a statistically significant outcome in each subset of your patients. A good example for this is we come to our clinic and you have locally advanced head and neck cancers who require cisplatin and eligible, who require cisplatin chemo radiation. However, so many of the times we see a patient who's above 65 or even 68, irrespective of their functional status. Just by seeing that number 68, 70, 72, we decide that maybe you don't want to subject them to cisplatin, and that may not be a very fair trial, because we know that cisplatin is much superior compared to the other platinum or cisplatin unfit patients. So therefore, we have extrapolated that the patient is cisplatin unfit based on age alone, and that is something that may not have been if we had focused on an age-specific trial where you're looking at a safer way of giving the same drug to an elderly population. The cons, of course, against it is that you're going to have a smaller sample size. It's going to be more expensive. Maybe a more aggressive therapy, like either multiple chemotherapy or polychemotherapy drugs, polytherapy regimens may not be included or may not be studied in this cohort. So, and you have all these multiple trials with the same for stage specific or for diagnosis specific, but if you just separate their ages out, they're not very economical to conduct. Now that we have decided what the patients are and how we're going to arrange a trial, whether we're going to do it for an age-specific patient or unspecific, we're going to talk about a little about drug trials. Not much. It's just that when efficacy and safety data comes in phase 2, of course, but when you have a dose-specific trial or concept of dose escalation, which comes under phase 1, phase 2, this thing about dose escalation is that you start the patient on a particular dose and it doesn't suit them, so you escalate. So there's another nicer concept which was studied where they included patients with comorbidities or functional dependence. So suppose you have one comorbidity and functional dependence and they tolerate it, then maybe you can increase it and add more comorbidities and functional dependence. So therefore you start the trial including patients who are fit and non-frail, and then you include them into fit but frail, and then you include maybe non-fit, non-frail to see if the allotted treatment is safe in them also. So the last part when we come at the end of trial designs is the endpoints, what we want or what we see specific that we can apply in elderly individuals when we are designing a trial. One is that we know chemotherapy trials usually take include patients who are almost 5 to 10 years younger than what we see in the real world data, right? And in them, OS or overall survival becomes so important because you're looking at efficacy overall and or DFS overall. But in an elderly population, that it might be slightly changed because you want to take into account safety or functional independence or other parameters. So we'll talk about how we can think of designing trials which go beyond just a numerical OS or a DFS. One is, of course, including co-primary endpoints, which is very popular with cardiovascular trials in the elderly. For example, they look at death, hospital admissions, symptomatic heart failures, use of another drug, and all of them form separate primary endpoints, right? But what that leads to is that one, it dilutes the results because then it becomes very difficult to extrapolate it. And of course that, and the problem is that the statistical design also becomes really difficult. But one good thing about having multiple primary endpoints is that it looks beyond efficacy. It looks to a reasonable extent, it looks at safety being at par with efficacy. The other way of combining multiple endpoints would be a composite endpoint. Now, composite endpoints, you also look at the same outcomes. For example, you can look at QOLs or treatment effect, or you can look at a particular toxicity, or you can look at ability to carry out ADLs, and all of them are given the same or equal weightage or importance, and all of them are yes or no. So if you have a composite endpoint, it has a more clinically meaningful outcome compared to an efficacy endpoint alone. The major advantage of having a composite endpoint compared to a co-primary endpoint is, of course, the statistical design becomes a little easier. However, the disadvantage is apparent that when you have lots of endpoints trying to be one primary endpoint, it really dilutes your results. And therefore, your extrapolation of your results then becomes questionable. So when we are developing in composite endpoints, we need to look at whether the individual components of the composite are meaningful, whether they are relevant, and whether and for the study to be clinically positive or ultimately positive, whether clinically more important components of the composite endpoint should at least not be affected negatively. So in that way, we have an endpoint in an older individual, for example, an entity called therapeutic success. And now you can define, this was studied in as an endpoint where it combined efficacy, toxicity, and patient compliance. Where the patient compliance, which is defined as whether they have completed the allotted therapy. Now you are looking at three things all rolled into one, which may be clinically meaningful, but of course, when you're designing a trial, the results become difficult to extrapolate. The next endpoint that we can look at is treatment-free survival or time to failure. So when you have the time between when you start therapy to when you end therapy or discontinuation because of any reason, either due to progression or due to death, you can take it as a TT, you can define it as TTF, and it becomes a clinically meaningful endpoint in the elderly population, because once the patient is on treatment, you're assuming that it will lead to toxicity. You're assuming that the quality of life might deteriorate during the chemotherapy, but it's an opportunity to take into account the role of toxicity when you are in the intended therapy. But all treatment, although this is especially suitable for palliative chemotherapy as well, because you're taking into account the time where the discontinuation or chemo breaks will add to life rather than be considered something that has led to that it becomes a limitation, because you're not taking into that into account. Then the next endpoint that we often look at in trials, and it is very commonly used now as a secondary endpoint or an exploratory endpoint, is quality of life. URCTC has an elderly specific QOL as well as a Q-twist, which is the sum of the health state durations, and it can be used to compare your treatment arms when you're planning an intensive regimen versus observation versus any other regimen, which is the standard of care. The last one I would like to talk about is preservation of functional capacity or independence. This, like the composite endpoint of a therapeutic success, is one of the endpoints which are clinically more meaningful. So this was first studied by the Geriatric group, or the French group of geriatric oncology, where they looked at the primary outcome as instrumental ADLs which were not decreased by more than 2 points. And that was perhaps a clinically meaningful endpoint in patients who were diagnosed to have breast cancer, who were undergoing adjuvant therapy. And then you could tell the patient that, even though you are elderly and this chemotherapy is mandated, that we could give you this chemotherapy, this regimen could be given, because it will not alter your ADLs during the planned therapy. Coming to designing clinical trials. So once we know that randomized phase 3 trials, obviously gold standard, whether it is in an elderly population or a younger population. Just skip this, just go to the next. Yeah. So when we are conducting trials, we need to look at whether we are going to be conducting trials which are between treatment regimens, or whether they are between treatment strategies. For example, when you're talking about treatment regimens, they include like that studied in CalGB where they looked at single versus poly chemotherapy in elderly breast cancer patients. They incorporated the use of a modified Bayesian study design. So the advantage of that is that when you have an elderly population, you don't want to subject them to toxic chemotherapy. So you have a smaller, and also you don't want the population to be at a risk of ineffective chemotherapy. So by having a dynamic study design, you can incorporate a smaller population who will be subjected to an ineffective chemotherapy regimen. Then the next thing is when we design a clinical trial is to talk about treatment strategy. This is just like to quote the example where because in an elderly population, you're always at two minds of not giving chemotherapy. So when you plan a regimen, you design it in such a way that whether you will give chemotherapy versus observation alone in an elderly population. And this is a trial that they did in elderly high-risk breast cancer patients in those who were above 70 years of age, and it was called the ACTION trial. And the recruitment failed because when they took the consent of the patient and they told them that, look, had you been 70 years, had you been younger, you would have definitely received chemotherapy. But now that you're older and we don't know if it'll benefit you, and it might possibly be harmful, but definitely for your stage of the disease, you require chemotherapy, but we're not perhaps going to give it because you're older. And maybe you might get randomized into receiving therapy versus observation alone. They recruited only 4 patients over 10 months because most of the women just opted to undergo standard chemotherapy irrespective of age. So when we are designing trials in an older individual, we need to take that choice into account, and we need to expect that and we need to take into account that age per se, that is the chronological age per se, should not be a determinant of treatment strategy, but rather it should be a stratification of functional aging. Coming lastly to cohort studies, which is something that we do very often, because it's easy to do and it doesn't require the grants and the insurances which of course are required by randomized trials. So in our clinic, what can we do to improve patient recruitment so in our clinic, how do we improve the way we approach a geriatric patient, and how do we learn from them, and how do we use them as a resource to better care that we can give to them as well as future elderly population. One is obviously you have the data, and we can always go back and do an efficacy safety data. For example, just how many of them with geriatric population have we given maybe dose-dense chemotherapy for breast cancer? Have they been able to take it? How many of them have we given a poly chemotherapy regimen, for example, FLOT or FOLFIRINOX? And is tolerance or safety compromised in the elderly population or not? Then the other thing that we can look at when we're in our clinic is to look at dietary, demographic, or social issues, or even psychological issues that have not been studied. One of them, each component of geriatric assessment, whether it's the mini mental state or the mini nutritional state or something as simple as sarcopenias, is waiting to be explored in the clinic, because we just don't have that data from India, or even from the rural versus the urban population. The other cohort, the other study that we plan is a longitudinal cohort or a prospective cohort. One is that we can do validation studies. So all of the geriatric assessments which have been spoken about by the previous speakers, it can be validated in our population. We can obviously do surveys or we can also, like how we are talking about the short geriatric elderly geriatric score development tools in India. We can develop a tool for assessing geriatric function, or whether to assess nutrition, whether to assess psychosocial issues, whether to assess survivorship issues. We can develop tools in our population. Lastly, once you finish trials, and we have talked about observational trials, observational studies where we're looking at cross-section surveys, or where we're talking about cohorts, either retrospective or prospective, we come to collaborative study. There are several collaborative groups which, though haven't done geriatric specific trials, but they do collaborate to develop guidelines on how to manage geriatric cancer patients. Most of these obviously deal with assessment and prevention of toxicity rather than evaluating newer modalities of therapy. The very rare examples from more hematological cancers, like development of rituximab or venetoclax or ibrutinib, because they're considered chemo responsive diseases, which obviously, and then in a cohort of patients who are unfit for intensive chemotherapy. But these are efforts which we must pool and combine to make sure to develop trials that we can look at altered management strategies or alternate management strategies in geriatric population. For example, it could be something as like breast cancer or gastric cancer, that would we change therapy in them? Would we change the way we treat in them? Should they have a different treatment strategies? Should we not do aggressive surgeries? There's so many questions that we don't know, because the trials obviously have not focused on this population. And the only way that we can get this kind of data is to have a collaborative effort from all academic or private centers in India, because only then we'll have a very consolidated effort in improving geriatric research as well as outcomes. So I would like to end my talk by saying that, by summarizing my presentation, is that one, when we see geriatric patients in our population, we must, in our OPDs, we must have a set tool, and we must stratify them according to geriatric assessment tools, however briefly, into fit, unfrail, fit, and non-fit, frail, so that we can include them in the trials which are appropriate for their functional aging rather than a chronological aging. We must also allocate treatment according to fitness, and we must try to include our geriatric population into trials which are ongoing or running if they meet the inclusion criteria. We can also look at other endpoints which are not usual endpoints like DOS or DFS, but to have composite endpoints of quality of life or physical independence or therapeutic success, or endpoints like that which are more clinically meaningful in a geriatric population. We must obviously utilize novel trial designs and strategies, and not just intensive chemotherapy versus observation alone or de-escalation of care, because we don't know about disease biology in geriatric population only. Thank you. I'll be happy to take any questions.
Thank you, Dr. Swaratika. I think it was a slightly tough topic given the lack of evidence in this group of patients, but I think you covered most of our doubts and questions pretty well. I now request Dr. Tarachand to talk on a topic that concerns actually our core competency on whether we can reduce doses, dose modify based on the available knowledge. Dr. Tarachand.